Antidepressants. Antidepressants such as selective serotonin reuptake inhibitors are frequently prescribed during pregnancy for women with depression and anxiety. Although negative side effects and risk to the baby can occur when taking these medications, in many cases the benefits and safety to the mother outweigh the risk. Maternal, fetal, and neonatal effects. SSRIs can cause thrombocytopenia and persistent pulmonary hypertension in newborns. Opiates. Opiates include drugs such as morphine, methadone, Demerol, OxyContin, Dilaudid, and heroin. Many opiates are frequently used and prescribed by physicians to treat chronic pain. However, they are very addictive. Heroin is the most frequently abused drug in pregnancy because it is easy to obtain and is cheap. Heroin rapidly crosses the placenta within 1 hour, leading to quick exposure to baby. Opiates are CNS depressants, and they generally leave individuals experiencing feelings of drowsiness, mental dullness, and stupor. Heroin acts as an appetite suppressant, and patients abusing it should be evaluated for poor nutritional intake and inadequate weight gain during pregnancy. These patients are also tested for STDs, especially HIV infection, because of the increased risk noted when sharing needles. Pregnant women who abuse opiates have an increased risk for developing chorioamnionitis, cellulitis, and endocarditis. Maternal and fetal effects. With opiate use, there is an increased incidence of placental abruption, intrauterine growth restriction, preterm labor, and fetal death. Because of the addictive nature of opiates, such as heroin, patients will typically alternate between periods of overdose and periods of withdrawal. These episodes expose the neonate to intermittent hypoxia, which increases the risk for meconium aspiration syndrome. Heroin use can lead to maternal kidney and liver disease, heart and lung infections, and severe respiratory distress. As a result of the highly addictive nature of heroin and other opiates, these medications cannot be immediately stopped. The sudden discontinuation of heroin can cause dangerous complications for both mother and baby, the most serious of which is death. Neonatal effects. Opiates such as heroin frequently cause neonatal abstinence syndrome. These infants can experience seizures, birth defects, and dysfunctions in brain organization. Diagnosis and management of substance abuse. It is not uncommon for women with substance abuse disorders to obtain prenatal care late in their pregnancy, if at all. The women may fear that the baby will be taken away if a healthcare provider finds out she has a substance abuse disorder. Statistics show that mental illness often accompanies substance abuse disorders in pregnancy. For these reasons, it is important for nurses to carefully assess their patients for any signs or symptoms of substance abuse and/or mental illness and report their findings to the proper members of the healthcare team so that the patient can get access to needed care and treatment. In recent years, there has been an increased push to reduce the numbers of prescribed opiates for both pregnant and non-pregnant patients and replace these medications with something safer and less addicting. Women with opiate abuse may need to be treated with methadone or buprenorphine under the watchful care of a medical provider to safely wean off the drugs. Methadone can be taken orally and is long-acting, providing consistent blood levels to decrease the adverse fetal effects of wide swings in blood level found with heroin use. The daily dose can be gradually decreased to wean the woman off the drug. However, if the baby is born before the drug is discontinued, the newborn must withdraw from methadone after birth. Buprenorphine may be used instead of methadone. Although neonatal withdrawal still occurs, it is shorter and less severe than with methadone. Ensuring the patient has access to treatment resources is important because research has shown that the greatest risk for substance abuse relapse is in the intermediate postpartum period because patients think they no longer run the risk for causing harm to the baby. Women who are actively seeking or receiving treatment should be strongly encouraged to hold and bond with their baby. Those who are not currently using drugs but are receiving methadone or buprenorphine can and should be encouraged to breastfeed. To reduce the number of women abusing drugs in pregnancy, Some states have moved to pressing criminal charges against women found to have a substance abuse disorder in pregnancy. However, the Association of Women's Health, Obstetric, and Neonatal Nurses, AHWAN, opposes this action because it can impede women coming forward and admitting they are abusing drugs out of fear of incarceration. The AHWAN recommends universal substance abuse screening for all patients, as well as priority to substance abuse treatment centers for those who are pregnant. Should be able to identify patients who need help in relation to substance use and abuse and ensure the appropriate care for both the woman and their babies. Application of the nursing process, maternal substance abuse. Nursing care related to substance abuse may occur during the antepartum, intrapartum, and postpartum period. Antepartum period. Assessment. Polydrug abuse appears to be the most common substance abuse problem among women. And all women should be screened at the first prenatal visit for tobacco, alcohol, and other drug use. Substance abuse occurs in all populations. The nurse should not make assumptions based on class, race, or economic status. Certain behaviors are strongly associated with substance abuse: seeking prenatal care late in the pregnancy, failing to keep appointments, and following recommended regimens inconsistently. Women who use drugs have low self-esteem. They are dealing with conflicting issues: the physical and psychological need for the substance, the need to deny that the substance is harming the fetus, and guilt that they may be responsible for harming the fetus. Fear of prosecution for use of illegal drugs may prevent the woman from seeking prenatal care, increasing risk for the woman and her fetus. In addition, many women with substance abuse problems face discrimination and resentment from healthcare professionals who direct their frustration at the woman rather than the problem. Given the powerful deterrence to self-disclosure, extensive history taking provides the best opportunities to determine current and past substance abuse. The nurse taking the health history should maintain a non-judgmental attitude, exhibit patience and empathy, and display an attitude of concern for the woman and her infant. Medical history. Determine whether the woman has medical conditions that are prevalent among women who use drugs, for example, seizures, hepatitis, cellulitis, STDs, hypertension, depression, and suicide attempts. Current problems may include insomnia, panic attacks, exhaustion, heart palpitations, depression, and suicidal ideation. Obstetric history. Evaluate for past and current complications of pregnancy. Spontaneous abortions, premature deliveries, placental abruption, and stillbirths are associated with substance abuse. Current complications may include STIs, vaginal bleeding, and an inactive or hyperactive fetus. Fundal height may be inconsistent with gestational age, suggesting fetal growth restriction. Investigate emotional responses such as anger or apathy regarding the pregnancy. These feelings are particularly significant during the latter half of the pregnancy, when the normal feelings of ambivalence are usually resolved. Negative feelings toward the pregnancy may interfere with prenatal compliance with recommended care. History of substance abuse. An accurate history of substance abuse is difficult and depends in large part on the way the healthcare worker approaches the woman. A sincere, non-judgmental, and empathic approach promotes open exchange of information. Suggestions for interviewing are given in box 11.3. Ask about all forms of drug use, including cigarettes, e-cigarettes, over-the-counter drugs, prescription medications, alcohol, and illicit drugs. Examine patterns of drug use, which can range from occasional recreational use to weekly binges, to daily dependence on a particular drug or group of drugs. Identification of patient problems. Some women acknowledge the use of harmful substances but do not fully understand the adverse effects. Other women are aware of the risks but are unable to stop using these substances. Common patient problems include lack of knowledge of the effects of substance abuse on self and fetus and inability to manage stress without the use of drugs. Both of these problems can result in a need for health teaching. Planning. Expected outcomes. Expected outcomes are that the woman will do the following. 1. Identify the harmful effects of substances on herself and her infant. 2. Verbalize feelings related to continued use of harmful substances. 3. Identify personal strengths and accept resources offered by the healthcare delivery system to stop using drugs. Interventions. Effective interventions for substance use require the combined efforts of nurses, physicians, social workers, and numerous community and federal agencies. Nurses should realize that progress is slow and frustrating. The major priority is to protect the fetus and the expectant mother from harmful effects of drugs. Examining attitudes. When working with pregnant women with substance abuse problems, nurses should identify their own knowledge level, feelings, and prejudices. They may have limited knowledge about perinatal substance abuse and negative attitudes towards mothers who abuse substances. Nurses may be angry at the woman who not only engages in self destructive behavior, but also may be inflicting harm on her fetus. Maintaining feelings of empathy or concern without becoming judgmental or even unknowingly punitive to the pregnant woman may be difficult. Nurses also may feel helpless and discouraged when the pregnant woman continues to abuse drugs despite the best efforts of the healthcare team. In-service education, professional consultation, and peer support are all helpful for professionals working with pregnant women who abuse drugs. These processes can allow opportunities for discussion and sharing of feelings, problems, and particularly troublesome treatment issues. Preventing substance abuse. Participate in campaigns to prevent substance abuse throughout the community. Provide accurate information in terms that the patients can easily understand. Use posters, diagrams, pamphlets, and other visual aids to describe the effects of tobacco, alcohol, and other drugs on the fetus. Post visual aids in schools, supermarkets, shopping centers, and other areas where women of childbearing age will be exposed to them. Focus on the benefits of remaining drug-free, which include a decrease in maternal and neonatal complications. For example, the effects of smoking tobacco are dose-related and cumulative, and nurses should encourage and support cessation at any point during pregnancy. Women who use alcohol during pregnancy may not realize the effects on the fetus. Social drinkers will often stop drinking once they know about the dangers. Those with heavy alcohol use need counseling and referral for further treatment. Communicating with the woman. Ask the expectant mother about stressors in her life that may be contributing to her substance abuse. Additional stressors may include inadequate housing, economic predicaments, intimate partner violence, and emotional or physical illness. Be honest at all times while displaying a patient, non-judgmental attitude and genuine interest and concern. This is especially important when the woman relapses into substance abusing patterns. Allow her to express guilt and reassure her that abstinence is possible and that she can and must begin again. Helping the woman identify strengths. Assist the pregnant woman with substance abuse problems in identifying personal strengths because she generally has a poor self-image. Acknowledge her actions when she abstains from drugs or alcohol for even a short time. Praise for maintaining an adequate weight gain and attending prenatal classes may increase her confidence and compliance with the recommended regimen of care. Providing ongoing care. At each antepartum visit, consider the current status of substance abuse, social service needs, education needs, compliance with treatment referrals. Address current drug use because women may change their pattern of drug use during pregnancy. For example, they may stop using cocaine but may increase their use of heroin or alcohol. Verify compliance with recommended treatment regimens such as antepartum clinics and chemical dependence referral programs. Coordinate care among various service providers such as group therapy and prenatal classes. Establish communication with all agencies that provide care, and facilitate communication that helps the woman with a chaotic lifestyle meet treatment objectives. Provide continuing prenatal education about the anatomy and physiology of pregnancy and consequences of prenatal substance abuse. Describe how the newborn benefits when the mother abstains from using drugs, including tobacco and alcohol. Drug screens will be performed periodically throughout the pregnancy. Praise any attempts at abstinence and encourage the expectant mother to try again if she relapses. Assess signs of maternal attachment to the fetus because it may help her reduce or eliminate her substance use. Fetal movement often increases the woman's awareness of the fetus and may lead to a discussion about her plans for the infant and changes in her life that have occurred or will occur. Help her make realistic plans for care of the baby. Include support persons if possible. When the woman's partner abuses substances, she is more likely to continue to use them or to stop during the pregnancy but start again after birth. Explain to the partner the importance of avoiding use for both members of the couple to enhance the outcome of the pregnancy and avoid exposure of children to the adverse effects of substances. When women use substances during pregnancy, Child welfare services may be involved to ensure the safety of the infant after discharge. The infant may become a ward of the courts and be placed in foster care until her mother can show she is in rehabilitation. Use therapeutic communication techniques to help the mother express her feelings about this loss. Help her make plans for implementing changes that will allow her to be with her infant. Evaluation. Interventions have been successful if the expectant mother identifies the harmful effects of substance abuse on herself and on the fetus, discusses her strengths and her feelings about continued use of substances, and is receptive to assistance to stop using drugs. Intrapartum period assessment. Nurses who work in labor and delivery units should become skilled at identifying drug-induced signs and symptoms. Cocaine. Behaviors associated with frequent or recent use of cocaine include profuse sweating, hypertension, tachycardia, and irregular respirations combined with a lethargic response to labor and apparent lack of interest in the necessary interventions. Additional signs include dilated pupils, increased body temperature, and sudden onset of severely painful contractions. Fetal signs often include tachycardia and excessive fetal activity. Fetal bradycardia and late decelerations may occur. Emotional signs of recent cocaine use may include angry, caustic, or abusive reactions to those attempting to provide care. Emotional lability and paranoia are signs of cocaine intoxication. Heroin. Typically, the pregnant woman dependent on heroin comes to the labor and delivery unit intoxicated from recent drug use. When the effects of the drug begin to wear off, withdrawal symptoms may be observed. These include yawning, diaphoresis, rhinorrhea, restlessness, excessive tearing of the eyes, nausea, vomiting, and abdominal cramping. Identification of patient problems. One of the most immediate patient problems during the intrapartum period is potential injury of the mother, fetus, and newborn because of physiologic and psychological effects of recent drug use. Planning, expected outcomes. The major goal or expected outcome for this patient problem is that the woman and the fetus will remain free from injury during labor and childbirth. Interventions. Preventing injury. A laboring woman has recently used a substance. The nurse should intervene to meet the needs of the woman and the fetus for safety, oxygen, and comfort. Admitting procedure. Two nurses may be needed to admit the woman into the labor unit and to persuade her to assume a safe position. One nurse helps the woman into bed, initiates electronic fetal monitoring, and begins administration of oxygen as needed. The other nurse acts as the communicator. A woman who has recently used a drug may have difficulty following directions. She should hear only one voice telling her what to do. This nurse states firmly what is happening and exactly what the woman should do. Lie on your left side. This helps us watch how the baby is doing. This gives you more oxygen. Maintain eye contact with the woman while giving her instructions. Setting limits. It is essential to set limits to protect the safety of the mother and the fetus. For instance, the mother cannot smoke. The nurse may say it's difficult not to smoke, but there is real danger to everyone if you smoke when oxygen is being used. The mother who must remain in bed may become agitated. The nurse must say, I know it's hard to stay in bed, but we can't take good care of the baby when you walk. If walking is safe for the woman, the nurse should set limits about where she can walk in the labor room, not to the cafeteria. Initiating seizure precautions. The laboring woman who recently used cocaine is at risk for seizures. Take the following seizure precautions. Keep the bed in a low locked position. Pad the side rails and keep them up at all times. Check the oxygen and oxygen administration equipment. Make sure that the suction equipment functions properly to prevent aspiration. Reduce environmental stimuli, lights and noise, as much as possible. Maintaining effective communication. Establishing a therapeutic pattern of communication is essential. Avoid confrontation. Instead, acknowledge feelings. I know you hurt and are frightened. I'll do everything I can to make you comfortable. When the woman is abusive, be careful not to take the abuse personally or react in a defensive manner. Examine your own feelings when women are abusive and acknowledge when anger is getting in the way of providing care. Another nurse may need to assume care of the woman for a time to allow some relief from being the target of unrelenting abusive comments or actions. Providing pain control. Pain control for women who are substance abusers poses a difficult problem because it is often impossible to determine the type or combination of drugs that were used before admission. If pain medication can be administered safely, do not withhold it under the false assumption that the woman does not need it or that medication will contribute to her chemical dependence. Include non-pharmacologic comfort measures such as sacral pressure, back rubs, a cool cloth in the forehead, and continual support and encouragement as for any other woman in labor. Preventing heroin withdrawal. To prevent heroin withdrawal during labor, give as ordered to the woman who usually receives it at a chemical dependence center if she did not receive her daily dose. Administer it intramuscularly if the woman is nauseated or vomiting. It is important to avoid the use of opioid agonist-antagonist drugs such as butorphanol, Stadol, and nalbuphine, Nubane, in women who are opiate dependent because acute withdrawal signs and symptoms will occur in the woman and the fetus. Evaluation. Both the expectant mother and the fetus may have experienced the harmful effects of drugs throughout pregnancy. However, the interventions for this patient problem can be considered effective if neither the woman nor the fetus sustains additional injury during labor and childbirth. Postpartum period. During the postpartum period, nursing care is focused on helping the mother with bonding, providing infant care, and planning to provide care of herself and the infant after discharge. Observe for signs of recent drug use and continue to assess the vital signs and level of consciousness of the mother. Observe the mother-infant interaction so that bonding and attachment can be promoted. This is a major concern at this time. Encourage the woman to continue her efforts to stop taking substances. Women who stop or reduce use during pregnancy may return to using at previous levels after pregnancy and need support to continue abstinence. Referral to social services and child protective agencies may be necessary for the follow-up care of the mother and the infant. Birth of an infant with congenital anomalies. Even when everything goes according to plan, childbirth is a time of stress for parents. Their anxiety about the condition of the infant is obvious as they carefully trace the features and count the fingers and toes of their newborn. When the infant is not perfect but is born with anomalies, the parents are often overwhelmed with shock and grief. What may appear to be a minor defect to healthcare workers may seem a severe impairment to parents. Nurses have an opportunity to help the family adjust and cope with their feelings. Factors influencing emotional responses of parents, timing and manner of being told. At one time, common practice was to remove the infant from the delivery area before parents could see a congenital anomaly and to tell them about it later. This practice changed, however, when it was realized that parents experienced less stress if they were told at once and were permitted to hold their baby if the physical status of the infant allowed. The manner of presenting information also changed. Physicians and nurses became aware of the importance of helping the parents accept and bond with the newborn. Prior knowledge of the defect. Although ultrasonography does not identify all fetal anomalies, many parents became aware of congenital anomalies during ultrasound examinations performed during pregnancy. These parents have time for anticipatory grieving before the birth. They may not demonstrate the shock and disbelief at the birth that are seen in parents who are unprepared. Their reaction should not be interpreted to mean that they do not experience grief, but rather that they have completed some of the early phases of grieving before the birth. Their grief is real and profound, even though it is expressed differently. One couple was aware from 18 weeks of gestation that the fetus had hydrocephalus and protrusion of brain tissue from the skull. The mother elected to carry the fetus to term. The infant would have every chance at life. When the infant died within minutes after birth, the parents calmly held their child and called the infant by the name they had selected several weeks previously. The only overt signs of grief were silent tears and a request to see their clergy. Once the anomaly is discovered by ultrasound, the pregnancy is no longer seen as normal, and the focus may be on specialized care for the mother in preparation for the birth. Parents may feel isolated from those with normal pregnancies. Some parents seek information from parents who have a child with a similar anomaly. The full extent of the problem may not be known until after the birth. There may be a long period of worry and fear between the ultrasound diagnosis and the birth. Type of defect. Although any defect in a newborn produces extreme concern and anxiety, certain defects are associated with long-term parenting problems. Accepting an infant with facial or genital anomalies is particularly difficult for the family and the community. The face is visible to everyone, and parents are fearful about whether the child will be accepted. If the defect is cleft lip and palate, the parents are concerned about surgical repair. They are often anxious about how grandparents and siblings will accept the child. With time and support, parents often work out unique methods to help the family develop strong feelings of attachment. Gender is at the core of a person's identity, and any defect of the genitals, however slight or correctable, arouses a deep concern in both parents. Some anomalies, such as hypospadias, opening of the urethra on the underside of the penis, are repaired in early childhood. Other genital anomalies, such as ambiguous genitalia, when assignment of gender is in doubt, cause extreme concern in the family and affect such basic issues as what to name the infant, how to dress the infant, and how to respond to questions about the infant's gender. Irreparable defect. Although the initial impact of any defect is profound disappointment and concern, when the defect is irreparable, the parents must grapple with the knowledge that the infant will have a lifelong disability. Examples of irreparable defects include Down syndrome, microcephaly, and amelia, absence of an entire limb. Grief and mourning. Grief describes the emotional response to loss. Mourning is the process of going through the phases of grief until the loss can be accepted and resolved. Birth of an infant with an anomaly evokes a grief response. The family must mourn the loss of the perfect infant they imagined during pregnancy. They must detach from and mourn the fantasy baby to be able to attach to the actual infant. Early emotions include denial, anger, and guilt. Denial and disbelief are the initial reactions of most parents to the birth of an infant with a congenital defect. How could this happen? Anger is often a pervasive response and may take the form of fault-finding or resentment. Anger may be directed toward the family, the medical personnel, or the self, but it is seldom directed toward the infant. Guilt may be expressed as a question of responsibility for the defect as many parents search for a cause. I shouldn't have worked so much while I was pregnant. Other emotions include fear, which may be expressed as concern about what will be done in the immediate or distant future, surgical procedures, complicated care, the infant's potential for a normal life. Sadness and depression, manifested by crying, withdrawal from relationships, lack of energy, inability to sleep, and decreased appetite, may precede acceptance and resolution. Gradually, often after a prolonged time, the feelings of sadness abate and the family is able to adapt to the loss and resolve its grief. Considerations. Assisting with the grieving process. Whenever possible, both parents should be present when they are told about the infant's condition. The nurse should use therapeutic communication techniques to help them discuss their feelings and fears. They should be given as much information as possible about the anomaly before the birth. If the infant will go to the neonatal intensive care unit, the tour before the birth may help them understand the type of care their infant will receive. At birth, the parents continue to grieve the loss of the perfect infant they expected and form an attachment with this newborn. Whether the parents learned about the problem before or after the birth, it is helpful if the nurse remains with them as they go through the initial phase of shock and disbelief. The nurse maintains an atmosphere that encourages them to express their feelings by listening carefully to what the parents say and reflecting the content and feelings they express. For example, the mother of an infant girl with cleft palate says, "How could this happen? I should have gone to the doctor earlier." A helpful response might be, "It sounds like you feel responsible for this problem. Actually, we don't know the exact causes of cleft palate, but let's talk about how you are feeling." This offers reassurance, but keeps the interaction open to explore the underlying feelings of guilt the mother may be expressing. Nurses should recognize that grief responses vary among individuals, and cultural and religious beliefs affect the expression of grief. Members of some groups express grief openly by crying, becoming angry, or seeking comfort from a support group. Those in other cultures, e.g., Asian and Native American, may appear stoic and may not reveal the depths of their grief. In some cultures, such as Hispanic, it is acceptable for women but not for men to grieve publicly. The couple should be offered a private room if possible. The infant should be examined in front of the parents so that they can ask questions. Information about normal needs of the newborn should be given at the same time as information about the anomaly. Promoting bonding and attachment. A priority nursing intervention is to promote bonding and attachment, which may be disrupted when the infant is born with an abnormality. The process is facilitated when the nurse communicates acceptance of the infant. Bonding. The nurse handles the newborn gently and presents the infant as someone precious. Parents are particularly sensitive to facial expressions of shock or distress. The infant should be called by name. Many nurses emphasize the normal aspects of the infant's body. She's so alert and she has beautiful eyes. Perhaps it is most important to help the parents hold their infant as soon as possible. Touching and cuddling are essential to caring. Figure 11.3. Providing accurate information. Nurses who work in perinatal settings should be aware of follow-up treatment and timing of surgical procedures for common anomalies so they can clarify and reinforce the information provided by the physician. This involves discussing the plan of care with the physician, as well as researching the nursing care that will be required. Parents develop trust in the healthcare team when consistent information is presented clearly and explained fully. If possible, one primary nurse or a team of nurses should work with the family throughout the hospital stay. The nurse should assess the parent's understanding of the condition and the treatment plan. Parents often need information repeated frequently because it is difficult for them to absorb all they are told at this time of intense emotion. Facilitating communication. Nurses are sometimes fearful of being asked questions they are unable to answer, or they fear they will say the wrong thing. The most helpful course of action is to answer questions as honestly as possible. If uncertain about information, say so. I'm not sure about that, but I'll find out for you. In addition to answers, parents need kindness, support, and genuine concern. It is crucial that family members communicate with one another as well as with the healthcare professionals. Information and empathy should be offered consistently to both parents. Fathers should be included in all discussions, demonstrations, and care of the infant. Without this attention, the father cannot be expected to support his partner, explain the infant's condition to relatives and friends, or cope with his own shock and sadness. The nurse should assess the mother for signs of postpartum depression. The person should be made aware of the mother's increased risk for prolonged depression. The signs of depression and the differences among normal baby blues, normal grieving, and postpartum depression should be explained. Participating in infant care. Parents should be involved in giving care to the infant as soon as possible to increase bonding and help them feel they can be real parents to the infant. Providing care for the infant also helps reduce parental anxiety as they get to know their baby. Planning for discharge. Teach parents the special feeding, holding, and positioning techniques that their infant needs. Early participation in infant care fosters feelings of attachment and responsibility for the infant, as well as increasing feelings of confidence. They should also know what type of follow-up care with the healthcare provider is necessary and what other services may be needed. Provide other anticipatory guidance that may help prevent problems when the infant is discharged. The reaction and behavior of siblings depend on their ages and abilities to understand the needs of the infant. Young children, who are often jealous of the attention and care the infant requires, may regress to infantile behaviors such as bedwetting and thumb-sucking. Remind parents that this indicates a need for attention rather than naughtiness. Although grandparents can be a great source of strength and support, they also may have difficulty adjusting to the infant with an abnormality. When appropriate, and if the parents are willing, include grandparents when teaching the special care the infant will need. Providing referrals. Initiate referrals to national and community resources as needed. In addition to a referral to the social worker or grief counselor in the hospital, parents may also benefit from information about the Easter Seal Disability Services, the March of Dimes, or the Disabled Children's Services of the Public Health Department. In addition, organizations such as the Shriners provide funds for the care of children. Support groups vary among communities, and perinatal nurses may wish to provide a list of names, addresses, and telephone numbers of these organizations. Perinatal loss. Perinatal death can occur at any time. Early spontaneous abortion, ectopic pregnancy, fetal demise at any point in pregnancy, stillbirth, or neonatal death when the infant survives for a few days or weeks can be equally devastating for the parents. The death may occur after a complicated pregnancy or one in which all seemed well until the baby died. Parents may have a short time with their baby while it still lives or none at all. Parents experiencing perinatal death often feel alone in their grief. Friends and family members may be hesitant to discuss the loss for fear of saying the wrong thing. They may be uncomfortable with the topic and change the subject when parents want to talk. Early pregnancy loss. Early pregnancy loss from spontaneous abortion or ectopic pregnancy may precipitate intense grief in the parents. The parents may not yet have told family and friends about the pregnancy. Those who do know may minimize the grief that occurs at this time. Comments such as, "You shouldn't have any problems getting pregnant again," discount the intensity of the parents' feelings. Frequently, the health care of a woman experiencing early pregnancy loss focuses on her physical needs with little attention given to the emotional needs of the woman and her family. In a small study of such women, Johnson and Langford, 2015, found that bereavement interventions provided immediately after the pregnancy loss enhanced women's ability to cope. Concurrent death and survival in multi-fetal pregnancy. Parents experience conflicting and complex feelings of joy and grief when one or more infants in a multi-fetal pregnancy live and one or more infants in the same gestation die. Parents do not grieve less for the dead infant because of the joy they experience in the surviving child. For parents experiencing survival of one infant and death of another, the grieving process may be more complicated. They may have fears about the health of the surviving infant, especially if the infant is preterm or ill. They may be unable to grieve for the dead child because of their concerns and responsibilities for the surviving child. They also may experience problems with attachment to the surviving infant because of grieving and fear that they will lose the infant as well. In addition, they may receive less support from others compared with parents who have lost their child in a single gestation. Parents who experience the death of one infant and the survival of another need the same interventions as those offered for parents who lose a child in a single gestation. Those interventions include allowing the parents to hold the dead infant and gathering mementos. In addition, nurses should be prepared to confirm the cause of death, if known, and the health status of the surviving infant. Perinatal, palliative, or hospice care services. Some parents learn that the fetus has a condition that is terminal. They may choose to continue the pregnancy and deliver at term, knowing that the infant will survive only a short time. Perinatal, palliative, or hospice care services provide care by nurses experienced in hospice or palliative care. These nurses assist the family through the process of birth, death, and grief. The emphasis of care is on promoting quality of life, minimizing suffering, and supporting parents in their grief. It allows parents to plan for the birth and death of their baby. They make choices about care and make memories that make their parenting more meaningful, even though it lasts only a short time. Previous pregnancy loss. Women who have experienced previous pregnancy losses, regardless of the gestational age at the time of the loss, often have higher levels of anxiety, grief, depression, and post-traumatic stress than women who have not experienced such loss. Healthy children does not reduce the degree of anxiety during a pregnancy that follows a perinatal loss. Parents may delay telling family and friends about the pregnancy until they feel confident about the outcome. They may not tell those who do not already know about the loss of the previous pregnancy. Some do not prepare the baby's room at all during the pregnancy. Others wait until near the end of the pregnancy to make preparations to bring an infant into the home. Conflicting emotions of excitement, fear, and doubt occur as the pregnancy progresses normally. Early prenatal care is especially important during a pregnancy after a loss. Both parents may be more comfortable with more frequent contact with the healthcare provider. Women tend to be extra careful to do what is recommended in pregnancy and hypervigilant about signs that might indicate something is wrong. Less fetal activity than usual is very worrying, and feeling the baby move is reassuring. They need frequent reassurance about the status of the fetus and emotional support throughout the pregnancy. Although mothers may request extra diagnostic testing to help relieve their anxiety, they may not always feel as reassured by normal test results as they had hoped. It is important for nurses to provide an opportunity for these mothers to express their distress and fears. Referrals to support groups or mental health providers may be appropriate. Application of the nursing process. Pregnancy loss. Assessment. Nursing assessment of the family that has experienced the loss of a fetus or infant requires sensitivity. Collect as much information as possible before meeting the woman and her family for the first time so that hurtful mistakes can be avoided. Knowing the child's gender, weight, length, gestational age, and whether any abnormalities were noted will help the nurse communicate effectively. Many perinatal units design a sticker or symbol to place on the door and chart so that all staff who encounter the family will be alerted that the infant has not survived. This visual symbol diminishes the chance that an uninformed person will make inadvertent comments that cause pain. Nurses are often unsure about how to interact with family that has experienced the loss of an infant. It is helpful to acknowledge the situation and clarify the nurse's role at once. I'm Dawn, and I'll be your nurse today. I'm so sorry for your loss. What can I do today that would be most helpful to you? This is not an appropriate time for self-disclosure or for false reassurance. Keep the focus on the family's response and their ability to support one another. Initial grief responses are similar to those expressed by parents of infants with anomalies. Crying and expressions of anger often occur during the woman's stay in the birth facility. Guilt is often an underlying feeling as the parents search for a reason for their child's death. Nurses who provide home care or make follow-up telephone calls should be aware of subtle cues of grief such as sighing, excessive sleeping, apathy, poor hygiene, and loss of appetite. These signs are especially important when assessing members of cultural groups who do not display grief publicly. In addition, nurses should observe for the signs of postpartum depression, post-traumatic stress disorder, and panic disorder, which may occur after perinatal loss. Evaluate the availability of a support system that includes family members or faith leaders. Ask whether the family would like a spiritual advisor called. The family may want the infant baptized or blessed. Assess the father's needs as well because they are sometimes perceived as needing less support than the mother. Fathers grieve differently from mothers. An acceptance of the differences in their grieving style, tolerance, and respect for each other may enable couples to strengthen their relationship during this experience. Identification of patient problems. Perinatal loss affects the entire family. Many families experience changes in their relationships and family processes because of grief. Planning. Expected outcomes. Expected outcomes for changes in family processes are that the parents will do the following. 1. Acknowledge their grief and express the meaning of the loss. Share their grief with significant others. 3. Provide support to each family member. Interventions. Allowing expression of feelings. Stay with the parents as they express their feelings. Allow them to cry or respond as they wish. Parents may want to have some time alone, but may also appreciate having the nurse sit quietly nearby. When they are ready to talk, listen attentively. Acknowledge the infant. It was once believed that when an infant was stillborn or died shortly after birth, the less parents knew of the infant, the less they would grieve. The infant often was whisked away so that the parents never saw their newborn. Relatives disposed of the clothes and the infant equipment before the mother returned home, and the parents were left with very few memories of the infant's birth. The response to perinatal death changed as nurses discovered that the most helpful interventions for grieving parents were those that acknowledged the rights of the baby. These include the right to the following. Be recognized as a person who was born and died. Be named. Be seen, touched, and held by the family. Have life ending acknowledged. Be put to rest with dignity. Allow the parents to talk about the baby as much as they wish. Refer to the infant by name. If the infant lived for a time, talk about what happened during the time and answer any questions the parents have. When it is dying, allow parents to hold and care for their baby. Take pictures of the infant if the parents wish. Presenting the infant to the parents. When the baby dies, the way in which the infant is presented to the parents is extremely important because these are the memories they will retain. Parents should be prepared for the appearance of the infant, especially if maceration, peeling, of the skin is present or there are disfigured areas. If necessary, wash the infant and apply baby lotion. The sense of smell is very powerful. Applying baby lotion provides olfactory stimulation. Wrap the infant in a soft, warm blanket. Some parents may wish to participate in bathing and dressing the baby. If possible, bring the parents and the infant together while the infant is still warm and soft. Keeping the infant in a warmed incubator may be necessary if some time elapses before the parents have contact with the infant. If this is not possible, rewarm the infant under a radiant warmer. Wrap the infant in warm blankets. Allow the parents to keep the infant as long as they wish, and tell them to feel free to unwrap the infant if they wish. When the stillborn infant has severe deformities, explain the defect briefly and gently. Wrap the infant to expose the most normal aspects. When the infant has deformities of the head and face, wrap the infant with the blanket draped loosely over the most severely affected areas so that the parents do not see those areas first. Use diapers to cover genital defects and booties and mittens to cover abnormalities of the hands and feet. It is not advisable to try to hide the defects completely. Allow parents to progress at their own speed in inspecting the infant. Parents may look at the abnormality or choose to leave the infant wrapped. They may quietly discuss positive features of the infant. He has your ears. Look at her long fingers. Some parents may provide care before their baby dies. If death is near, ventilators and other equipment may be removed so that the parents can feel closer to the infant. They may hold the infant during the dying process. Many feel that this is very helpful to them, as it provides a chance to say goodbye and is the only opportunity they will have to parent their baby. Other family members also may be present at this time. Stay with the family if they wish, to help them at this difficult time. Allow as much privacy and time as the parents and other family members need to be together. Sensitive to cues that members of the family want to talk or prefer silence. A sympathetic smile or a promise to return at a certain time and then returning at that time are equally important. It is all right to say, "Do you want to talk?" Then all that is required is listening quietly and reflecting the mother or father's feelings. Allow the parents to be alone if they wish and check intermittently to see if they need assistance. Although many parents may want to spend time caring for or holding their baby before or after death, others may not. It is important not to make the parents feel guilty or that they should behave in a certain way. Nurses should accept that each family needs to go through this difficult experience in their own way. Preparing a memory packet. Mourning requires memories. Nurses have explored measures that help the family create memories of the infant so the existence of the child is confirmed and the parents can complete the grieving process. Helping families create memories and providing support are part of a perinatal grief support nursing care quality measure under development by the Ahwan. Most parents treasure a memory packet. Prepare one that includes a photograph, a birth identification band with the date and time of birth, the crib card with the infant's name, weight, and length, a tape measure, and a blanket and cap used for the baby. If the baby has enough hair, ask the parents for permission to cut a lock of hair from the nape of the neck where it will not be noticeable. Some hospitals offer commercial remembrance materials to parents. The packets or boxes may contain clothing for the baby to wear and provide a place to keep baby items. Make paper handprints or soft modeling material impressions of the infant's hands and feet. Take photographs of the infant to help parents remember the baby's features and assist them through the grieving process. Take photographs of the infant dressed and undressed, wrapped and unwrapped, and of the parents and other family members with the infant. The infant should be positioned in natural newborn positions for the photos, such as lying on the stomach, with the knees tucked under the head, turned to one side. Professional photographers may be available from the Now I Lay Me Down to Sleep Foundation, a nonprofit organization that provides bereavement photos to families. A list of photographers and their locations is available at www.nowilaymedowntosleep.org. Keep the memory packet and photographs on file if the parents do not wish to take them home because they may want them at a later time. Many couples feel these concrete forms of remembrance are invaluable in helping them remember the baby as a person who really existed when they have no other signs of that life. Respecting cultural practices. In some cultures, seeing or holding the baby after death is not acceptable. Cutting a lock of hair may not be permissible. It is culturally unacceptable in certain groups to take photographs of a person after death. Therefore, ask permission before taking pictures. Pictures taken before death occurs may be more acceptable. Expression of grief may be loud and open, or parents may appear stoic depending on cultural expectations. The nurse should be accepting of the family's method of coping with their loss. Assisting with other needs. If the family includes other children, help the parents plan how to tell them about the death of the expected infant. Information about sibling responses and needs based on the ages of their other children. Provide the parents with written information about perinatal loss, grieving, and children's responses to death for later use. Other family members and close friends may be important in helping care for siblings as the parents cope with their own grief. Offer to call clergy or other faith leaders and discuss plans for a funeral or memorial service, if the family wishes. Parents may want to discuss this with their own faith leader, or a hospital chaplain may assist them. Discuss the normal grieving process and explain that a considerable amount of time is involved. Describe common reactions that family members and friends might have. For example, some family members or friends may minimize the loss, whereas others, in a misguided attempt to offer comfort, may urge the couple to have another baby. Let them know that grandparents also go through grief because of the loss of their grandchild, as well as the pain their children must endure. Providing follow-up care. Parents may find that friends and relatives expect them to recover quickly from perinatal loss and cannot understand their continued grief. Suggest that they allow the parents to tell the story of the infant as often as they want, because this helps them in their grief process. Suggest that they help parents collect and talk about mementos to help establish memories of the infant. Siblings are often expecting to be a big brother or big sister and need help understanding why that will not occur. Help the parents explore how they will tell their other children that the new baby will not be coming home. Explain that some young children think they have done something to cause the death and need reassurance. They may have questions such as, is the baby still dead? Or is the baby alive? That should be answered simply but truthfully. Because the mother and the father experience grief in different ways, they may not understand each other's responses. Mothers who want to talk about the loss repeatedly may have partners who deal with that grief by being stoic and brooding or by focusing their energy on work. Emphasize the individuality of grief and that no single method or duration of grieving is right for everyone. Couples usually want to know the cause of their infant's death. An autopsy may be recommended, even if the cause of death is obvious. This gives parents the most accurate diagnosis for risk for recurrence in a future pregnancy. In some cases, the cause may never be found. Referral for genetic counseling may be appropriate for some parents who are concerned about the risk for a repeated tragedy. Future pregnancies will be stressful, and the woman will need closer follow-up than usual to identify any problems as soon as possible. The anxiety may continue in the neonatal period, and parents may need education and emotional support during this time. Providing referrals. Many birth agencies offer bereavement programs or counselors to provide ongoing help to parents. A social services referral is important. Calls made during the first week, 1 to 2 weeks later, at the time of the postpartum checkup, and at the 1-year anniversary are helpful. Sympathy cards may be sent by agency staff with a list of resources that may be helpful. The greatest help often comes from contact with people who have experienced a similar loss, and a variety of support groups have been formed. To resources at the birth facility or in the community designed to help parents cope with loss. Many internet resources are available. Examples are the MISS Foundation at misschildren.org and Helping After Neonatal Death, HAND, at handonline.org. Some families join internet perinatal loss support groups. Such groups may be particularly helpful after the immediate period surrounding the death. Extended family and friends may no longer be as supportive at this time and do not realize the length of time involved in grieving. Gaining a feeling of control over their lives and being able to make decisions gradually develop as the parents move towards healing. Evaluation. Nursing care has been successful if the family members share their feelings of loss and grief, communicate them to their significant others, and are supportive of one another. Adoption. Although pregnancy is a planned and exciting time for some, it can be a time of great strife and distress for others. women, pregnancy can be unexpected, and for a variety of reasons, they may find themselves choosing adoption for their child. Caring for a patient deciding on adoption can present interesting challenges for women's health nurses. Deciding for adoption can be one of the most difficult yet rewarding experiences for a birth mother. Although the birth mother may find a great sense of joy in knowing she could give her child a better life through making a decision for adoption, she may also struggle with intense feelings of guilt, depression, and regret. Adoption has changed greatly in recent years and now offers birth parents the option of choosing how involved they would like to be in their child's life. The decision for adoption is a very personal one and will look different for each person. For some individuals, it is very important to them that they have a relationship with their child and that they have an opportunity to be a part of the child's life, whereas for others, having a relationship may prove too emotionally difficult and they choose to not maintain any relationship or communication with the child or adopted parents. For this reason, many adoption agencies now offer a variety of choices to birth mothers deciding on adoption, ranging from having an open adoption that permits the birth mother to have regular contact with the child and adoptive family, to partially open or to closed adoptions. The relationship between birth mothers and adoptive parents may vary greatly among patients. Some birth mothers can interview and pick with which family they would like to adopt their child. They may have had time to develop a close relationship throughout the pregnancy, with the adoptive family attending doctor appointments, and in some cases even attending the birth. In other circumstances, the birth mother may choose to let an adoption agency make the decision on where to best place her child, and not know or have any contact with the adoptive family at all. It is important that healthcare providers are equipped to deal with both the physical and emotional needs of patients deciding on adoption, as well as the adopting family. Knowing if the patient has made a decision for adoption, as well as whether an adoptive family has been chosen and who she would like to be a part of her delivery, are vital pieces of information a nurse should have to best support the patient. Healthcare providers should be sensitive and non-judgmental in their speech and care of the patient deciding on adoption. It is important that nurses withhold any personal biases they may have and remember that making a decision for adoption is a courageous act of love by the birth mother, not abandonment. Nurses should make every effort to respect and meet any special needs or requests the patient may have during the birth experience. Most birth mothers make a plan for how much contact they would like with the infant, how involved in the infant's care they would like to be, and how involved they would like the adoptive parents to be during the hospital stay. It is common for birth mothers to want as much information as possible about the infant and have some time alone with the infant. The birth mother should be encouraged to take as much time as she would like with the infant, and hospital mementos such as keepsake footprints, baby bands, and infant blankets should be given to the birth mother if she wishes. Such actions provide memories of the infant and help the mother through the grieving process that accompanies deciding on adoption. It is important that the nurse is able to form a rapport and trusting relationship with the birth mother. Therapeutic communication techniques are useful in helping the mother explore her feelings. Although the mother has made a choice for adoption, the grief she feels may be similar to that experienced when there is death. Her grief may not be shared with family or friends, and those close to her may not understand her feelings. It is imperative that the nurse acknowledge any feelings the mother may have, while avoiding offering advice or coming across as judgmental. The ability for the patient to see the nurse as an advocate for her feelings and well-being will assist the patient in being able to successfully transition through a very emotional and difficult experience. In the event that adoptive parents have been chosen, the nurse should acknowledge their needs and emotions as well. All efforts should be made to give adoptive parents a private room to process through emotions and adapt to their new role as parents. Nurses should teach adoptive parents how to care for their newborn and what to expect in growth and development. This family will need all teaching that is standard for new parents. Adoptive parents may be anxious, overwhelmed, and even experience post-adoption depression. Demonstrations, as well as return demonstrations, may be helpful in assisting them in learning to care for their newborn. Prenatal psychological complications. Although pregnancy and birth is a time of great joy and excitement for many women, for others it can be a time of great stress and sadness and bring to the forefront underlying psychological disorders. Psychological disorders can arise at the beginning of the pregnancy, or existing disorders can be intensified by the huge hormonal surges and shifts that occur during pregnancy. Left untreated, perinatal psychological complications can result in serious harm to both the mother and infant. Historically, many obstetricians and women's health professionals have been ill prepared to address the needs of patients with psychological complications during the perinatal period. Fortunately, in recent years, increased attention has been given to the importance of appropriate screening and treatment for this vulnerable population of patients. Perinatal mood disorder. Perinatal mood disorder, also known as major depressive disorder, is generally characterized as unipolar depression or a major depressive disorder with associated psychotic features. Signs and symptoms of a mood disorder include anxiety, agitation, a constant sad mood, feelings of worthlessness, difficulty thinking or concentrating, loss of energy, crying fits, fatigue, headache, and loss of appetite. Psychosis-associated mood disorders include symptoms of delusions, auditory hallucinations, cognitive impairment, disorganized thinking, failure to distinguish delusions from reality, poor hygiene, and anger. These types of disorders affect 3% to 6% of perinatal patients, with the disorder most frequently being seen in adolescent patients and those in their early 20s. Although the disorders occur more often during the postpartum period, prenatal episodes are also possible. Postpartum depression. Postpartum depression is defined as depression that takes place after childbirth and persists longer than 2 weeks. In contrast, postpartum blues, baby blues, maternity blues, which is a mild, transient condition that resolves within 2 weeks. Postpartum depression typically presents within the first 3 months postpartum and has the potential to last up to a year. Postpartum depression is the most common complication of childbirth, with up to 20% of mothers experiencing postpartum depression during one of their pregnancies. Women who have a history of depression are at an increased risk for being affected by the disorder. Although postpartum depression can affect anyone, after giving birth, patients with a history of sexual abuse, patients experiencing an unexpected or unwanted pregnancy, those who smoke, and those who formula feed their babies are all at increased risk for the disorder. Some women may be reluctant to care for their infants or continue to breastfeed because of the extreme feelings of depression. However, research has shown that breastfeeding can actually decrease the risk for developing postpartum depression and in some cases may even be beneficial to those experiencing postpartum depression because it allows them to bond and connect with their baby despite the depressive feelings they have. As medical professionals, it is imperative to remember that each patient's experience is different and that care and treatment options should be individualized to the patient. It is also important to note that acknowledgement of depressive symptoms, screening, and treatment vary throughout different countries and regions and may be accepted differently based on the parent's culture. A patient's family and support system should be a part of her care and treatment as much as possible because social support has been shown to play a significant role in a patient's ability or lack thereof to overcome this disorder. Postpartum psychosis. Postpartum psychosis is an intense type of deep depression or relapse of an underlying psychotic disorder such as schizophrenia. Postpartum psychosis is characterized by serious mood instabilities that peak from 48 hours to 2 weeks postpartum. To truly be characterized as a postpartum psychosis episode, the following criteria are required: major depressive disorder with psychotic traits, bipolar 1, bipolar 2, unspecified functional psychosis, schizoaffective disorder, or short-term psychotic disorder. Postpartum psychosis is a serious medical emergency that requires immediate intervention, usually hospitalization, psychotherapy, and appropriate medication. There is an increased risk for development of postpartum psychosis in women of advanced maternal age, as well as with those with a lower socioeconomic status. In addition to having symptoms similar to those seen with postpartum depression, symptoms of postpartum psychosis include the failure to be able to identify reality, confusion, auditory and visual hallucinations, insomnia, hyperactivity, suicide, homicide, and infanticide. Bipolar II disorder. Bipolar disorder is a combination of depressive and manic symptoms. There are 3 types of bipolar disorder, with clinical manifestations that differ for each type: bipolar 1, bipolar 2, and cyclothymic. A diagnosis of bipolar 1 requires manic episodes and depressive episodes. A bipolar 2 diagnosis requires depressive episodes and hypomania. and a cyclothymic diagnosis, requires recurrent mood changes of both depressive episodes and hypomania. Pregnancy often intensifies symptoms for the patient with bipolar disorder and can send them into a depressive or manic episode. However, many patients stop taking their medications during pregnancy out of fear they will cause harm to the baby. It is imperative that medical professionals work with these patients to establish risk versus benefit regarding medications during pregnancy. This may mean that the patient may have to continue to take medications despite known risk to the baby to ensure safety and well being to the mother. It is also important that patients are educated on the increased risk for mood disorders relapse with each subsequent pregnancy because this might play a significant role in the patient's family planning. Some signs and symptoms that accompany bipolar disorder are frequent mood swings, impulsiveness, loneliness, guilt, hopelessness, increased or decreased energy, irritability, euphoria, and excessive thoughts and speech. Postpartum anxiety disorders. Post-traumatic stress disorder, panic disorder, obsessive compulsive disorder, phobias, and generalized anxiety disorder are all considered postpartum anxiety disorders. The signs and symptoms of an anxiety disorder include inability to relax, restlessness, difficulty concentrating, irritability, insomnia, anguish about making decisions, irritable bowel syndrome, constant worrying, and the inability to stop worrying. It is estimated that 4.5% to 15% of pregnant and postpartum women have an anxiety disorder. Application of the nursing process. Perinatal psychological complications. Assessment. Women should be assessed for depression during pregnancy, at the birth facility, and during follow-up visits after birth. Early identification is paramount. The woman should be reassessed at each contact with healthcare providers, including follow-up telephone calls. Women whose infants are in a NICU should be assessed for postpartum depression during visits to their infants. Assessment tools such as postpartum depression predictors inventory revised may be helpful. This inventory identifies prenatal depression, life stress, social support, prenatal anxiety, satisfaction with marital relationship, history of depression, self-esteem, unwanted or unplanned pregnancy, marital status, socioeconomic status, childcare stress, infant temperament, and maternity blues as factors that may predict the likelihood of a woman developing postpartum depression. In addition, screening for excessive fatigue in the first 2 weeks after childbirth may help identify women who will later develop postpartum depression and enable them to get early treatment. Some examples of other screening tools include the Edinburgh Postnatal Depression Scale and the Postpartum Depression Screening Scale. Ask the woman if she is often sad or depressed, or if she has felt a loss of pleasure or interest in the things she once enjoyed. These questions may enable early identification and treatment of depression. Observe for subjective symptoms such as apathy, lack of interest or energy, anorexia, or sleeplessness. The mother's verbalizations of failure, sadness, loneliness, anxiety, or vague confusion are important cues. Focus on the frequency, duration, and intensity of the woman's feelings to determine their severity. Assess for objective data such as crying, sleeplessness, poor personal hygiene, or inability to follow directions or concentrate. Determine what, if any, support is available. Mothers with an absent or unavailable support system may feel increasingly isolated, leading to stress and a feeling that they are unable to manage. Inappropriate expressions of blame or anger toward the partner and unmet expectations of the baby or the parenting role are sometimes present. Identification of patient problem. Women with psychological disorders during the perinatal period lack effective coping techniques to manage the stressors associated with childbirth and parenting. Planning expected outcomes. To achieve the expected outcomes for this patient problem, the new mother will do the following. Verbalize feelings with the healthcare provider and significant other throughout the postpartum period. Discuss her own strengths. Identify available resources for the postpartum period. Interventions. Providing anticipatory guidance. Because of short hospital stays for new mothers and timing of the usual onset of affective disorders, Most incidences of postpartum depression and postpartum psychosis occur after the woman has gone home. Anticipatory guidance of the mother and her family is the most critical nursing intervention. Success of treatment is largely affected by early diagnosis. Prenatal period. Initiate a discussion with all pregnant women and their partners to provide anticipatory guidance early weeks at home. Explain the signs of postpartum depression and the importance of seeking early help to decrease the length of time the condition lasts. Discuss the need for frequent contact with other adults so the mother does not become isolated. Emphasize the importance of continued communication with the partner or a close friend who can provide support when loneliness or anxiety becomes a problem. Explain that adequate rest and nutrition can help the mother maintain energy and a feeling of health and well-being. Teach mothers and their support persons the signs of postpartum depression and other postpartum psychological disorders, including when they should seek help. Demonstrating caring. Conveying a caring attitude is an important nursing strategy to help mothers decrease their emotional distress and guide them in regaining their well-being during the peripartum period. Acknowledge that something is wrong and that the woman seems depressed. Spend time with her and reassure her that the condition is not her fault. Explain to the woman that what she is feeling is a common experience after childbirth. Encourage her to talk about her feelings and reassure her that help is available. Help the mother verbalize feelings. Because women are expected to be happy after giving birth, many women do not discuss their negative feelings with others. They may feel ashamed and believe a social stigma to admitting to depression at any time, and especially after giving birth. They may fear that their infants may be taken away from them if they disclose their problem. If they do discuss their feelings, their friends or even healthcare workers may trivialize the problem by making comments such as, "You'll get over it. After all, you have a beautiful baby." Women and their families minimize depression because they cannot find the exact cause. Recommend that although some of her feelings may seem unreasonable, anger, guilt, shame, the woman should acknowledge negative feelings to herself and insist that others recognize them too. Discuss the realities of parenting and the fact that it is often exhausting. It may be helpful to rehearse some of the situations that may occur, such as a fussy baby or being home alone and feeling lonely. Enhancing sensitivity to infant cues. Point out infant cues and explain their meaning. Model behavior to show the mother how to respond to the infant's cues. Suggest measures that may enhance her sensitivity to cues. Measures to help the mother relax may help improve her mood and her response to her infant. Assess the infant's growth and development. Depressed mothers may not give the care and nurturing needed. Determine the infant's weight gain or loss and observe the mother's response to the infant's crying. If the mother is breastfeeding, make suggestions to help her continue because it may increase her feelings of closeness to the infant. If she is taking a medication, be sure that it is recommended for use during lactation. Helping family members. Include the father in discussions about depression before and after the birth. Acknowledge his feelings and those of the mother. Stress his role in helping his partner and other family members. Offer practical suggestions of ways he can help manage the changes in their lives. Discuss ways to help, such as arranging for the mother to get more sleep and to eat better, which may help decrease her irritability and anxiety. Determine the father's need for additional support and explain the impact of postpartum depression on each family member. Emphasize the importance of the mother taking medications as ordered. Discuss signs that the mother's depression is worsening and when to call the healthcare provider. Providing help. Explore with the family practical suggestions on how to help the mother. Explain the importance of sleep and suggest that another family member care for the infant at night, if possible, to allow the mother to sleep. Because depressed mothers do not interact with their infants well, emphasize the importance of other family members holding and interacting with the infant. Discussing options and resources. Ask the mother about stressors in her life that may be contributing to her depression. Help her plan ways to reduce common areas of stress. Assist the mother and her partner to identify people who are available to provide support. Provide telephone numbers for local postpartum depression support groups. Internet sources are another place to find help. Examples are Postpartum Support International, postpartum.net, and the National Women's Health Information Center, womenshealth.gov. Evaluation. The interventions are successful if the mother does the following: talks about her feelings to staff and family members, identifies her personal strengths, assesses community and family resources, and makes plans to use them.